Welcome to From Care to Cure, an educational webinar series presented by the Massachusetts General Hospital Frontotemporal Disorders Unit. My name is Katie Brandt. I'm the Director of Caregiver Support Services and Public Relations for the MGH FTD unit. An important part of my role in our clinical research program is to coordinate educational opportunities for our community of persons living with a diagnosis, care partners, and healthcare professionals. It is our hope that these educational opportunities will improve the understanding, care, and treatment of frontotemporal dementia, atypical Alzheimer's disease, and related conditions. Our From Care to Cure educational series aims to empower families and our community members with knowledge and information presented by our expert team of staff and clinicians. I have often said that it is my hope and also my belief that the cure of tomorrow is not so far from the care of today for these devastating conditions. That is why I have asked Dr. Scott McGinnis to give today's presentation about a critical topic in our community, the advancement of research for treatment and a cure for frontotemporal dementia, Alzheimer's disease, and related conditions. Dr. McGinnis is a board-certified neurologist and instructor in neurology at Harvard Medical School, with expertise in the evaluation and treatment of patients with cognitive impairment and dementia. His research interests include frontotemporal degeneration, atypical Alzheimer's disease, and non-Alzheimer neurodegenerative dementias. He is an investigator in the Center for Alzheimer's Research and Treatment at Brigham and Women's Hospital and the Director of Clinical Trials for the MGH FTD unit. It is my honor to welcome Dr. McGinnis for the next presentation of our From Care to Cure 2021 educational series, Research to Develop Treatments for FTD, Alzheimer's disease, and related dementias.
Welcome to my talk on research to develop treatments for frontotemporal dementia, Alzheimer's disease, and related disorders. My name is Scott McGinnis, and as Katie mentioned, I'm a behavioral neurologist and a neuroscientist, and I work both at Mass General and at Brigham and Women's Hospital. So first, I wanted to just provide a little bit of an outline for the topics that we are going to cover in this talk, and wanted to highlight the main research goals, some of the most important research goals that we have in working on these disorders. And I'm going to highlight in my talk the critical importance of being able to identify a neuropathological diagnosis for our patients. And I'm going to review what that means. It really means what is happening in the brain at a microscopic level. And we will review the specific proteins that really define the different diseases that we think about in this field. So the first research goal is really to be able to have a means of identifying these misfolded proteins in people who are alive and walking around and in need of treatment, because historically the way that we've identified the treatments is only, the pathologies is only by looking at the brain in a pathological examination at autopsy. So the second key research goal is really to better understand the mechanisms of the diseases that we're talking about. And so what are the mechanisms of frontotemporal disorders? What are the mechanisms of Alzheimer's disease? And what are the mechanisms of even other diseases, such as Lewy body diseases, that we would consider in the spectrum of AD, FT, LD, and related disorders? And so how specifically do these misfolded proteins relate to the progression of the disease? How do they relate to the kind of degeneration or loss of brain cells in certain parts of the brain that give rise to symptoms? The third main goal that we're going to talk about is really to identify treatments that help to lessen symptoms. This is critically important. You know, the symptoms of these diseases are really what causes stress and what causes loss. And really, if we can develop treatments that lessen symptoms, then we would be really doing a great service. Obviously, I don't need to explain that to this audience. But finally, I think the overarching goal, and I think the goal that encompasses all of the other goals, is really to identify and develop treatments that slow or halt the progression of the disease. And these are what we would call disease-modifying treatments. At the end of the day, we want to develop a cure. We want to actually change what's happening in the brain to stop this kind of progressive process. That really is fundamental in no matter which of the diseases we're actually talking about. So to begin, let's actually dive in and take a look at these so-called misfolded proteins. We have specific names for specific proteins, and the main proteins under consideration in FTLD, which stands for frontotemporal lobar degeneration, are TDP43, tau, and FET. And when we're actually, these are all slides that, or these are pictures that are taken from actual pathology slides where a section of brain is examined microscopically, and various stains are used to highlight structures within and between brain cells. And each of these specific stains, where we actually see the brown in each of these slides, really reflects where the proteins are being identified. And in this case, this is a protein that's called TDP43. And we see in these areas that are brown where we're seeing accumulations of this protein, which are abnormal and they're not supposed to be there. They wouldn't be found in a healthy brain, but they are found in the brains of people who have FTD. But not everybody who has FTD actually has TDP43. A substantial proportion of people with FTD have an entirely different protein that is called tau. And we see tau here in this slide. And you can see it looks a little bit different from what we're seeing with the TDP. So the actual shape of the protein accumulations can be different in different diseases as well. Generally speaking, when a person has FTD that is due to tau, they're not going to have TDP43. And also vice versa. When somebody has TDP43, they're not going to have tau. The primary neuropathology, which is really the dominant form of misfolded protein that we see in any given patient, is really what defines the neuropathological diagnosis. And different people have different neuropathological diagnoses. We group based on these misfolded proteins. A much smaller proportion of people will have this FTLD FET. So the majority of people are going to have either TDP43 or tau. And I'll just note that when we use the term FTLD, frontotemporal lobar degeneration, we are using it in reference to the neuropathological diagnosis. So it's a point of confusion that comes up so often, whereas, well, why do you say FTLD in some cases and say FTD in other cases? Well, when we're saying FTLD, we're referring to the neuropathological diagnosis, i.e., which protein a person has. So, whoa, there's a lot going on this slide. let's walk through it a little bit, because I think to build on what I was just saying, I really wanted to highlight the distinction between what we consider to be a clinical diagnosis, such as behavioral variant FTD, or various different types of primary progressive aphasia, or ALS FTD, or a PSP syndrome, or a corticobasal syndrome. These are clinical diagnoses that are defined by the symptoms that a person has, and also by the locations in the brain that are affected. And typically we get symptoms because of location. That's kind of a fundamental principle that applies in every area of neurology, is that localization. When certain parts of the brain are affected by any sort of disease process, the symptoms that you get with that disease really depend and relate to the regions of the brain. On the other end of the spectrum, we have the neuropathological diagnosis. So this is really these are the categories of deposited proteins, these three main ones that we just talked about, for example. And this is really strictly defined by what we're seeing at the microscopic level. And the reason why this is such a busy slide with so many lines going in different relationships is that there's not a one-to-one correspondence between a person's syndromic diagnosis, in other words, the symptoms that they have and the clinical diagnosis, and the neuropathological diagnosis. And to make things even more confusing, these are terms that actually refer to very specific instances of neuropathology, so very specific neuropathological subtypes. So even when we delve in and look at FTLD that's related to and associated with tau protein, there are multiple different neuropathologies that really reflect the fact that tau can be affected in different ways. And when you're looking at the microscope, you're going to see different shapes and different patterns and different types of cells that might be affected in each of these different subtypes of FTLD that's associated with tau. And in some cases, you'll notice that the neuropathological diagnosis is very similar to a clinical diagnosis, as with progressive supranuclear palsy or corticobasal degeneration, corticobasal syndrome. And that's because when the syndromes and pathologies were initially associated, these were the dominant associations. So most cases of people who have the symptoms of a corticobasal syndrome are actually going to have corticobasal degeneration neuropathology, but it's not an exclusive relationship. Some people who have a corticobasal syndrome actually might have TDP pathology, right? So I don't want to get too confusing. I think it's what's most important is to understand that the relationship between a clinical diagnosis and a neuropathological diagnosis is not one-to-one. And it's critically important for us to, when we're making our diagnoses, really to diagnose both to the best of our ability. We want to know, obviously, what's going on in terms of the signs and the symptoms and the parts of the brain that are affected. But we also want to know what's going on at the microscopic level. We need to know what's happening at the microscopic level to develop the treatments and the therapeutics that have a potential to be disease modifying, because the mechanisms of a disease are what really give rise to the different neuropathological findings. That's just a very critical point to understand, that there are different disease mechanisms that operate in different neuropathologies, and you might have any given person with one single diagnosis behavioral variant FTD, but that clinical diagnosis does not tell us what the pathology is or what the disease mechanisms are. Moving forward, things are a little bit simpler when we're thinking about Alzheimer's disease, because we're not talking about really different, multiple different kind of misfolded proteins. We're really only talking about two: beta amyloid, which forms something called plaques, and tau, which forms something called tangles. And you might say, well, tau, we just heard about tau in FTLD. Well, yes, there are different types of tau. And just like there are different types of tau within the spectrum of FTLD, there's also Alzheimer's disease tau, which is fundamentally different from any of the tau subtypes in FTLD. So tau is an important protein in the brain, and it can be affected in different ways by different diseases. And so we see it as a defining feature, both in some cases of FTLD and also as one of the two main proteins that defines Alzheimer's disease. We do see different clinical and neuropathological relationships in the spectrum of Alzheimer's disease as well. And this is counterintuitive because we all learn that Alzheimer's disease is a disease that affects memory. And I think that's something that we're taught. It's what we're taught in medical school, but it's also kind of what we hear about just when we're reading about AD, or when we're watching a movie, or when we come across it in a magazine, or wherever we might come across a discussion, even in people's personal experiences, friends and family members. For the most part, there's this kind of association between Alzheimer's disease and memory. But when we take Alzheimer's disease as it's defined neuropathologically, defined as overaccumulations of these proteins, these amyloid plaques and these tau neurofibrillary tangles, that's Alzheimer's disease most fundamentally, when we have excessive amyloid and excessive tau. And the typical memory presentation of AD is not the only presentation that we'll see. In some cases, we see people who have posterior cortical atrophy, which is Alzheimer's disease that affects the back posterior parts of the brain preferentially, the occipital lobes and the parietal lobes early on, and gives rise to early visual impairment and early spatial impairment and other related symptoms along those lines. Or we might see Alzheimer's disease that causes progressive aphasia, and particularly a subtype of progressive aphasia in which retrieving words is the most prominent early symptom. We might also see Alzheimer's disease that presents with more behavioral or executive functioning difficulties. It was previously called frontal AD. Nowadays, we call it more behavioral dysexecutive AD. But this is a type of AD that actually might be confused with FTD because the symptoms are primarily relating to changes in personality, behavior, or executive functioning. So, when we were reviewing the prior slide on FTLD, clinical neuropathological relationships, there were some other primary progressive aphasias that were noted as clinical diagnoses. And so I think knowing that there is PPA that can arise in the setting of Alzheimer's disease as well highlights the fact that just kind of making a diagnosis of PPA doesn't even tell us necessarily whether a person has FTLD or Alzheimer's disease neuropathology. Just identifying that somebody has PPA doesn't tell us what is happening in the brain at the microscopic level, at the level of those misfolded proteins. And so it's a point that Dr. Dickerson makes in his talk, and makes it very frequently to our research trainees and really to anybody who has an interest in this field, it's really critically important to understand that clinical diagnosis and neuropathological diagnosis are not the same thing. And most often when we are considering a neuropathological diagnosis of Alzheimer's disease, we might consider it in the setting of people who have typical Alzheimer's disease with early memory impairment, but we also might entertain the possibility of AD in these additional presentations that in which other cognitive functions apart from just memory might be affected. And to be inclusive and really capture the full spectrum, very frequently we're also dealing with yet more proteins. And in the case of Lewy bodies, the protein is called alpha-synuclein. And the clinical presentations are usually in a spectrum that ranges from Parkinson's disease, which is a neurodegenerative disease that causes early motor symptoms like tremor and slowness of movement and rigidity, to another disorder called dementia with Lewy bodies, in which the symptoms are primarily cognitive and behavioral. A person might have formed visual hallucinations, dramatic fluctuations in attention, acting out of dreams, and also to varying degrees, those Parkinsonian motor signs as well. So we would use the terms DLB and Parkinson's disease as clinical diagnoses. They both occur in a neuropathological spectrum of Lewy body disease, which involves this protein called alpha-synuclein. And then finally, many people have vascular disease. These are blood vessels, and when blood vessels become affected in the brain due to a variety of reasons, most commonly it would be things like having high blood pressure or having diabetes or having too much cholesterol. We can see the brain being affected by that vascular disease as well. And I should note that many times the neuropathologies are not always exclusive. So we might see vascular disease in people who have any of the neurodegenerative diseases that we've already talked about. So that is kind of the foundation in terms of this is what we're trying to identify, these microscopic changes. And there is, and it's critically important for us to, in our efforts to develop treatments, to really have the best idea about what's actually happening at a microscopic level. How do we do that? Well, we have this term that we call a biomarker that really is just a fancy medical term for any test or study that we can do that might actually give us an indication of what is happening in terms of a disease process. So, many people are familiar with biomarkers in the realm of cancer, where there are certain blood tests like a CA-125 that might actually be a marker of a certain type of cancer. You can do the blood test and you can get some idea about the likelihood that a person might have cancer in their body by examining the level in the blood. Biomarkers in our field actually can range from things that we see in imaging and things that we see in biofluids, so proteins or other molecules in the blood or in the cerebrospinal fluid. And that's not even the whole scope of biomarkers, but those would just be some of the more common biomarkers, either blood biomarkers, CSF biomarkers, or imaging biomarkers. And the importance of biomarkers is that it really allows us to try to get an idea of what's happening in the brain without actually having to get a piece of brain and look at it under the microscope. We really rarely, sometimes we will actually do an actual brain biopsy, but we really try to avoid that. It's an invasive neurosurgical procedure, and so for the most part, we try to have our best guess as to what the neuropathology is through other less invasive means. And these studies, which many of you are familiar with, represent our coordinated efforts across multiple different research sites to develop better markers of disease. And in the spectrum of frontotemporal disorders, some of the two major ongoing studies are, one is called All-FTD, and then the other one is called Fortney. And All-FTD actually encompasses two separate arms, one of which is for families who might have a genetic form that is inherited of FTD that might be passed down from generation to generation. And then the artful arm, which is more for people who do not have suspected genetic FTD. But in both cases, and even in the case of Fortney, the studies are coordinated efforts to kind of develop imaging markers, biofluid markers, to understand the genetics of these conditions better so that we can make a diagnosis, a neuropathological diagnosis as early as possible, and also so that we have markers to follow longitudinally to really assess how a person's doing, from a standpoint of disease progression. And that becomes critically important as well when we're actually thinking about intervening with therapeutics. Of course, it's very important to measure how a therapeutic affects a person's symptoms. And that's why we ask questions. That's why we actually, do tests of memory and thinking. And, we have many endpoints in our clinical trials that fundamentally relate to, how is this person doing? How is this person functioning? But we also would like to be able to have a marker that actually tells us how active is the disease, that's completely independent from the symptoms that a person's having or the signs that we might find on exam. The same way that, in cancer, we can get a CAT scan at time point A and at time point B, and we can actually measure whether the tumor is growing. We want to be able to get images or blood tests or spinal fluid tests at time point A and time point B in our neurodegenerative disorders and really see whether our intervention is affecting the progression of the disease in that way. I'll just mention that Fortney, it stands for 4-repeat tauopathy, and that's a very specific neuropathology, neuropathological kind of entity where it encompasses, for the most part, progressive supranuclear palsy and corticobasal degeneration. So it certainly is pertinent. Fortney is pertinent to people who have, PSP syndrome and corticobasal syndrome, but there are also others who might have progressive aphasia, PPA, or even behavioral variant frontotemporal dementia, who actually have those pathologies, the PSP or the CBD pathology, again, highlighting the fact that pathological diagnosis is independent from clinical diagnosis. And so Fortney is really pertinent not only for our PSP and our corticobasal syndrome patients, but also for the efforts in FTD world at large. In the world of Alzheimer's disease and Lewy body diseases, we have similar studies. The Alzheimer's disease neuroimaging initiative was kind of the grandfather of them all. And ADNI really has been going strong now for well over a decade. And it really kind of showed the power of collaboration such that rather than working in, a limited kind of setting with a small sample size, you can actually come up with a research protocol that standardizes methods that can be employed all over the country, all over the world even, And that gives rise to a much larger and more powerful data set that might be open to any researcher who has a worthwhile question. And that's what all of these studies are doing, really. But ADNI was kind of the first one to do it, where there's both kind of a clinical dimension of characterizing the symptoms that a person has, and then there's an imaging dimension, and there's also tests of blood and spinal fluid and everything that we've already talked about. So ADNI is now in its third iteration. We have additional studies. We have LEADS, which is a specific study investigating people with early onset Alzheimer's disease, people who have onset of their symptoms before age 65. And in this, a group that is much more kind of enriched in these atypical presentations where a person might have posterior cortical atrophy or PPA due to AD or behavioral dysexecutive syndrome that is due to AD. So it's a very important study, one that we're very proud to be a part of. And then we have the dominantly inherited Alzheimer network, which is really studying familial Alzheimer disease. So the less common cases of Alzheimer disease in which there's a single gene mutation that actually gets passed from generation to generation that causes Alzheimer disease. In the world of Lewy body diseases, we have the Parkinson's Progression Markers Initiative. And the fundamental common denominator of all of these studies is that they really aim to develop better biomarkers, better means for us to diagnose and follow the diseases longitudinally. So shifting gears and actually thinking more about therapeutics, how does this translate into therapeutics? Very good question. There's generally a process of early development, which we call preclinical, which might be at the bench or in animal models, that precedes studies that are done in humans. So many times we hear about phase 1, phase 2, phase 3 clinical research studies in people, but kind of the foundation before we even get to these studies, we are investigating our therapeutics at a more basic level. And in some ways, it is easier to investigate a therapeutic in a preclinical model where you have kind of complete control of whatever might be most neuropathologically relevant. So we can develop, in the case of animal models, we can develop tauopathies, or we can actually develop animal models in which there's an overexpression of an overabundance of amyloid accumulation in the brain. And so there's a tight degree of control, here. But the question is always, how well does that translate into what diseases we're actually seeing in humans? And so certainly these are ongoing questions that are kind of beyond the scope of this particular talk. But I do want to highlight just how important a biomarker is, because if we're developing specific treatments that are, specific to these neuropathologies, specific to these misfolded proteins, in the more basic kind of foundational research work that we're doing, in order to apply them in research studies, we actually need to know what a person has going on at the microscopic level. And the fact is that without biomarkers, we cannot know that. So it's critically important for us to have the biomarkers for us to be able to conduct these phase 1, phase 2, and phase 3 clinical trials, particularly the phase 2 and the phase 3 clinical trials, where the effectiveness of an agent and the side effects are really being very closely looked at. Phase 3 is usually the final phase that a drug is going to go through in research before the Food and Drug Administration or whatever governing body is applicable geographically would be kind of making a decision about whether it can be approved to be prescribed in general by doctors. So, really, it's critically important in these studies, particularly these phase 2 and phase 3 studies, to answer the question, how effective is the drug and what are the side effects, and does the effectiveness outweigh whatever side effects might be present? So we talked earlier that there are kind of conceptually different types of interventions, and one would be a symptomatic intervention would be one that's really looking primarily at how effective the intervention is for kind of treating various symptoms that might arise. And so looking within the spectrum of what's going on right now in the world of FTD, we have studies of intranasal oxytocin, of low-dose lithium, and then studies of drugs, sleeping agents that are being investigated in people with PSP. Oxytocin is a hormone that we all make. It's a hormone that is important for social affiliation. It's, for example, it's this hormone that would be increased when a mother is bonding with her child. And there's some evidence from preliminary research that giving patients with FTD intranasal oxytocin might actually improve some of the symptoms that relate to changes in social behavior in the disease. Lithium is a mood stabilizer. It's already on the market for many, many years. It's been used as a treatment for bipolar disorder. It's also being studied for treatment of behavioral symptoms in FTD at low doses. And then the PSP study is one that's being done remotely. Again, the randomization here is really between two existing drugs that are already used to treat insomnia and a placebo, and really trying to get a handle on whether there's an intervention that might help with sleep dysfunction in PSP, which is a very common symptom. I also wanted to mention a non-pharmacological intervention that is being investigated both in Alzheimer's disease and FTD, transcranial magnetic stimulation. Also in other kind of forms, transcranial direct current stimulation you might hear of as well. These are ways to actually stimulate parts of the brain that might be affected in a disease to either increase their activity if they're underactive, or to kind of quiet down their activity if they're overactive. And this might be a way to enhance, say, language functioning if we're stimulating the language network in people who have primary progressive aphasia. That's not the only application. TMS and TDCS are being investigated for a variety of different symptoms in the spectrum of AD and FTD. And Dr. Eldaif, who's in our group, is one of the active people who's really kind of helping us conduct these trials in our lab. So fundamentally now, they're moving to disease-modifying treatments. We're thinking about a different category of intervention where we're actually trying to change what is happening in terms of those misfolded proteins in the brain. And some of the active studies right now, so accordingly, whenever we're thinking about disease-modifying studies, we have to ask the question, well, what is the pathology that the intervention is targeting? Because by definition, there almost has to be pathological specificity, because your drug is actually going to relate to specific mechanisms that give rise to those specific misfolded proteins in any given neuropathological disease. So it's appropriate to think, not just in terms of what are the disease-modifying treatments in FTLD. We have to kind of dive down and say, well, what are the disease-modifying treatments that are being developed for TDP 43? Because that's a specific neuropathological subtype of FTLD. Likewise, what are the disease-modifying treatments that are developed for FTLD tau? Those tauopathy cases, which is a different category, neuropathologically. And in the realm of TDP 43, there's a subtype, or even a sub kind of group of people who have TDP 43 that is fundamentally related to mutations in a gene called progranulin. Diane Lucenti will, in her talk, be covering kind of the genetics of FTD, and progranulin gene mutations represents kind of one of the major kind of categories of gene mutations that actually give rise to FTLD when it is familial. And one of the reasons why there's active research in this kind of subgroup of people who have progranulin gene mutations is that we have a relatively good understanding, or at least better understanding, of how the gene mutation actually causes the disease. It's very clear in the case of progranulin that when people have mutations in the gene, they are not making enough of the protein. And so when you don't get enough of this protein, which is important for the health of brain cells, your brain cells can become sick, and it can really kick off this neurodegenerative cascade. And so it's kind of a universally agreed upon goal would be to boost the levels of progranulin in people who do not have enough. And these two studies, basically, one of which is a phase 3 study being run by Elector, what the mechanisms of these drugs is really to raise the levels of progranulin in people who have progranulin mutations. And in this Elector drug AL001, what the drug does is it actually binds to this other protein called SORT1, which actually helps what the protein does is it removes progranulin from the brain. And so when people are not making enough progranulin and they're also removing what they have made from the brain, it can really kind of lead to, or it exacerbates the problem of not having enough. But if you can actually prevent this protein from removing progranulin, then you can boost the progranulin levels. And that's the mechanism of the drug. And that's why it's being studied. Now, you might ask, well, why can't I take this drug? Or, if I don't have, if I have some other form of FTD? Well, it doesn't really apply, because if the mechanism of FTD is not related to kind of having insufficiency of progranulin, then the drug isn't really going to help. So, it is a little bit frustrating. We would love to be able to identify a universal mechanism that really applies to everybody with FTD, but that's, unfortunately, it's a little more complicated than that, and there are different mechanisms, different disease mechanisms that apply in different people. This second study, this PROCLAIM study, is gene therapy. So it's actually it's providing a treatment that aims to kind of increase the production of progranulin by inserting a healthy gene. So it's an exciting mechanism, and we're definitely looking forward to seeing how things go in this phase 1/2 clinical trial. In the world of tau, there are different mechanisms that are actually being targeted, because there are different potential steps along the way between healthy and unhealthy, where if we actually intervene and kind of slow down the progression, we might actually improve the outcome. And so, this is kind of a real highly magnified kind of picture or cartoon that depicts something called a microtubule, which is a structure that's inside our cells, inside our nerve cells, inside our brain cells. And the tau protein, what it does, and so microtubules kind of form a scaffolding, they form kind of a transportation network within cells. And what tau does is it stabilizes these microtubules. That's what, we talk about the microtubule associated protein tau. That's what MAPT stands for. And so we want our tau to be healthy. We want it to be binding to our microtubules. And we want there to be kind of the right amount of tau. We don't want there to be too much. So when tau is healthy, it's not hyperphosphorylated. Hyperphosphorylation, it just means that there's kind of too much of a chemical reaction that gives rise to there being what's called phosphorylation, which changes the shape, it changes the conformation of the tau. And so some of the drugs that we're looking at are inhibiting this process of phosphorylation, because what happens when it becomes hyperphosphorylated is it disassociates from the microtubule and it aggregates. So aggregation represents another kind of place in the process where we have a potential to intervene. So we might actually try to prevent the aggregation of tau. But even once it's aggregated, and when it forms something like a tangle, which is depicted right here, we still have means to try and kind of remove that entity from the brain in and of itself. And that's where we have things like tau antibodies that are going to try to capture these aggregates of tau, as they are actually spreading. And because that's one of the things we've learned, is that when you have unhealthy aggregates of protein, it can actually spread from one cell to the next. And that might be one of the ways that these diseases actually progress, is from kind of the spread of unhealthy protein. And so if we can intercept it and remove it from the brain while it's being spread, that would be a way to actually effectively treat. And because tau is applicable both in Alzheimer's disease and FTD, some of these drugs, for example, antibodies against tau, are being studied in both of those arenas, both in people with FTD that's due to tau, and then also people with Alzheimer's disease. So that's what I'm talking about here in multiple phase 2 studies of anti-tau antibodies. Amyloid, beta amyloid, is the protein that is unique to Alzheimer's disease, and amyloid has been kind of the most extensively researched kind of therapeutic target in Alzheimer's disease, in part because we have pretty good evidence that it becomes abnormal early on, and we know that people who have genetic AD, for example, tend to overproduce amyloid protein. And so there's pretty good evidence that having too much amyloid in AD causes kind of toxicity and represents an important part of the disease process. So some of these therapeutics that are really kind of at the forefront now in terms of treatment considerations are antibodies that are going to bind to and help the body clear out the beta amyloid protein. One of these drugs, aducanumab, is under review right now by the FDA, and so we'll be learning in the coming months as to whether it gets approved. If it does get approved for clinical use, it will be a very important moment, because it will be kind of the first disease-modifying treatment that is approved for Alzheimer's disease. And so we're really kind of awaiting the FDA's decision there. There are some other antibodies, BAN 2401, donanemab. These have been in the news because there have been some promising results from some of the phase 2 clinical trials investigating these drugs. There are ongoing investigations in clinical trials to really kind of more definitively answer the question as to how effective they are. We also have a very kind of exciting treatment that we're involved in collaboration with some colleagues at MIT, which is gamma frequency stimulation, which actually relates to kind of ways that we can modulate the electrical rhythms of the brain in ways that can actually impact the health of brain cells. So it's really exciting work. And again, we're very much looking forward to kind of getting some results from some of the studies that are ongoing. So I wanted to wrap up by just highlighting the complexity that we're truly dealing with as a means of kind of understanding why it takes so long to develop an effective treatment. I think that one analogy that I like to kind of think about is really kind of thinking about how we understand cancer as a disease that involves kind of this proliferation of cells that can occur because of multiple actual changes. Okay, it's typically not one kind of change in a cell that gives rise to cancer. It's multiple changes that kind of overrides this kind of check that we ordinarily have against uncontrolled proliferation. In neurodegeneration, we're dealing with kind of the opposite problem, where a cascade gets started where there is a degeneration, a death of cells, an accelerated death of brain cells. And the more and more we're actually understanding is that there are multiple places where cells can be stressed that can actually contribute to the process of neurodegeneration. And in some cases, it might be degradation of important proteins in a cell. In some cases, it might be problems with kind of how a cell manages its kind of housekeeping in terms of taking out the trash and degrading kind of proteins, because we all have to degrade proteins. In some cases, it might be problems with energy production, what we get from mitochondria. In some cases, it might be having to do with the metabolism of DNA and RNA. In some cases, it might be really more just the problems with protein aggregation in and of itself. And it's important to know in different diseases, in different conditions, in different pathologies, various aspects of these kind of cellular processes might be preferentially affected. So you might have more mitochondrial dysfunction in one case, more problems with DNA and RNA metabolism in another. But it's also the case that you might have more than one process operating at the same time. And so they're not necessarily mutually exclusive. And I think where we're eventually going to have to improve is in our ability to identify the specific stressors that are operating, and so that we can provide treatments to really target those stressors and stop them and reverse the damage that they've caused. So we call this kind of precision medicine is kind of a catchword that we use that really refers in a general sense to kind of not viewing these conditions as monolithic. So, for example, not necessarily viewing Alzheimer's disease as one single process that affects everybody in the same way, but maybe a final common pathway that leads to the accumulation of amyloid, the accumulation of tau, but by which there might be multiple different routes, multiple different stressors that actually get you there. And so to really effectively treat it, we need to understand the specific stressors that are applicable in the given patient that we're trying to treat. So that is our task. That is what we're really eager to confront. We're eager to make headway. We are enormously grateful for our research participants, because without your participation, we have no way to improve our ability to diagnose these diseases early. We have no way to develop tools to monitor response to treatment and intervention. We have no way to really develop and improve our understanding of these very complex disease processes. And we are making progress. I think every year that I give this talk, I can think back. It gives me an opportunity to reflect on kind of the new progress that's available since the last time I gave the talk. And without fail, every year there is progress. It's even especially when thinking back to where we were in terms of our knowledge 10 or 15 years ago. Oh my gosh, it's literally unbelievable how much more we know about these diseases now than we did then. And most of that is because of our research participants. So thank you for your attention, and I hope that I get a chance to communicate with many of you on an individual basis. Happy to answer questions as they arise. Thank you.